Thank you, Austin. I appreciate it. First of all, thanks for having me here. Just a little background on me. I got excited about IR about 12 years ago when I was a first or third year med student. When I saw some pretty big procedures. I saw TIPS, I saw TACE, and I got really pumped about IR. And I think that's where a lot of medical students get excited about IR is sort of the big cases. And the as I got more involved with SIR, and then I met Dr. V, I learned that it wasn't just enough to be able to do these procedures. You got to get good at everything that is surrounding that, meaning you got to know when to and when not to intervene on a patient. You got to work them up. You have to know how to do that. You got to have a clinic for that. And then, of course, you need to be able to follow them longitudinally after you do whatever intervention you do. That, to me, is how I practice IR, and that is what I expect all my residents and fellows how they should be practicing IR. So I am extremely passionate about that way of practicing, and if that is something that is not happening with my residents and fellows, they know it, and I make sure to let them know that I'm not happy with them if that is not happening. So I'm going to work a little backwards here. So what I want to provide to you all is how I believe you can be successful in IR residency, and how I would, if I could mold my perfect IR resident, how that would look like, or who they would be. So with that said, I'm going to jump right into it. So let's talk about what IR is and what IR isn't. And before you talk about how to do well in IR residency, you have to know what you're getting yourself into. So what is IR? What IR is not is we are not surgery light. Do not for 1 second think that our schedule is easier than surgery schedules. I have left at 9 p.m. every single day this week. And I've loved staying. I believe it or not, I've loved every moment of that. So we are not surgery light, and nobody tells me what to do. If they want to consult me, I'm happy to see the patient. I'm happy to give my opinion, and then if they have an issue with that, they can talk to me, and then we can work together to figure out what is best for the patient. But ultimately, it's going to be my hands. If we do end up doing a procedure, it's my hands on the patient, and then it is my decision, and that is up to me to decide whether or not it's best for the patient. But to be able to do that, you got to have a really good understanding of the disease processes that we are involved in. You have to be good at clinical management, not just clinical IR, but also sort of the fundamentals of clinical medicine. You have to be good at all that to be able to have a good conversation with your referring physician, so that they know that you are that you know what you're talking about. So we are not surgery light. So what we are, however, is a clinical specialty. We are expected to have a strong clinical foundation, and we have to become disease experts. Whether it's for me, it's right now prostates. That's my big focus right now is BPH. So you got to get really good at BPH and become an expert in management of lower urinary tract symptoms. And finally, once you have accomplished all of that, you've become clinically solid, you've become a disease expert in that, then you can offer the patient what you're good at, which is delivery of minimally invasive medicine procedures. So with all that, the way I look at IR is that we are a surgical subspecialty. My day-to-day life is more that of a surgical subspecialty than it is radiology. So that's helpful. I want you all to remember what we are and what we are not, because that's going to frame, that's going to tell you what type of IR resident and how you should function as an IR resident. So when I look at an IR resident in Michigan, or where I did my fellowship in Medical College of Wisconsin, I'm looking for a certain type of person. And what I refer to that as a genotype. What is a genotype of a very good IR resident? They're self-motivated. You are entering a uncharted territory here. We are a relatively new specialty. So you got to be self-motivated. You have to know what you're looking for. And if it's not there at your program that you're going to, you got to build it yourself. You got to bring it yourself. So you can't be passive. You have to go out there and work to build the type of IR program that you want to be a part of. Second, as you probably can tell, I am all about this. Clinical. You have to be clinical. You have to know your disease processes inside out. And that comes from obviously being in IR and being in IR clinic, but also just consuming everything you can, from literature to books to and not just in IR, but also in other subspecialties. Go to the journals, go to urology journals. Most of my reading right now is not actually in IR journals, it's urology journals, because that's where the data on a lot of the up and coming transurethral treatments are coming up for BPH. So consume everything you can from literature perspective. This seems self-explanatory that the genotype of an excellent IR resident should be patient-centric and clinician-centric, but it's something that I will emphasize, because I think it's very easy at times in radiology to become just procedure-centric. Patient comes in, you do the procedure, they go away, you wipe your hands clean, done. That is not how IR is practiced, and that is not how you should be practicing. You got to focus on the patient, and something as simple as a thoracentesis. You cannot just wipe your hands clean. And that's the most easy of procedures, but you can't wipe your hands clean. You got to get that x-ray, and you got to follow that x-ray yourself, not rely on some other team to get that x-ray and see what, let them decide how to manage whatever complication, if there is one, and have them take care of that. That is your responsibility. And then finally, I want to see that an IR resident is very excited to build our specialty into a true clinical subspecialty where we are seen as that, and we are seen as sort of a surgical subspecialty, because that's what we are. But we need to get everyone else on board in medicine to see that. And that is up to you as an IR resident to do. And finally, we're rapidly changing. Our specialty is changing on a weekly, monthly, yearly basis. And the procedures that I'm doing today, that I did the last week, were not even a thing about 10 years ago. I did a prostate artery embolization, I did a geniculate artery embolization, and I did a PERC AV fistula creation. These were literally not around 10 years. Well, there were very, very few people were doing them 10 years ago. And that is now a very common part of our practice. So how does that manifest itself? So I've described to you the genotype, what I look for in an IR resident. What is the phenotype? How does that manifest itself? And what should you be, how do I know that an IR resident is excellent? I don't have to ask them to go see their patients. I don't need to tell them to follow up on their patients. They just do it because that's the right thing to do. And they're seeing their patients in the morning, of course, but they're also sometimes seeing them in the afternoon or evening, because sometimes that's what patients need. And they go above and beyond for their patients. Next, excellent communication, not just with the patient, but also the referring team. To me, you can't just leave a note and say, they can read my recommendations. I like to close the loop, meaning I do a procedure. Of course, I leave a note with my recommendations, but then I also call the team and I go talk to the family and close the loop in that regard and make sure that everybody is on the same page. And that saves a lot of hassles. And one thing you got to remember is our referring physicians sometimes have no idea what we're doing. When I tell them that I did a prostate artery embolization, they have no idea what that entails, what they should be looking for. Should they be freaking out if the patient has a fever in the next day? So they don't know what we do. So it's our job to educate them and close the loop. An excellent IR resident shows improvement from day one from their final day. And nobody expects an IR resident to come in knowing everything on day one, but they do show steady improvement, and they show clinical improvement, and they're teachable. They pick things up quickly, and they take that and they apply it to their practice when they're seeing patients. And finally, you always have to be on the lookout. A good IR resident is always on the lookout for how to improve our practice. This is one of the fun parts. This is both frustrating, but also very fun. The frustrating part is that there are times that we have to do a lot of work where we are deficient in certain systems issues in IR, and you have to identify those and go out and fix them. And more than likely, wherever you end up for residency, it's not going to be a perfect place. So it's your job to identify the gaps and fill them. So what are the goals? The goals of IR residency, you have to do a couple things. You have to get really good at radiology, so radiological interpretation. You have to get very good at the technical skills, which we've already discussed. So ultrasound guidance, CT guidance, wires, catheters, and all the different tools that we use, some big, some small. But you also have to get very good at the fundamentals of clinical medicine. And this is kind of going back, Dr. V and Zane were talking about the importance of your Med 4 rotations and the importance of your surgical intern year and integrated ICU experience throughout your residency. These are places where you get to learn medicine, and do not underestimate how important that is. We have sick patients coming down to IR, and routinely you're expected to, especially patients who are getting moderate sedation. We don't have an anesthesia team available at all times. What happens if the patient gets respiratory distress, or what happens if they become suddenly hypotensive? Do you know how to manage that? You better be able to, because that's it. You're the only doc in the room. So you got to get good at that. And the bigger procedures that we're doing with moderate sedation, the more complications that can arise. So you just got to get good at clinical medicine. And then finally, clinical IR. That's sort of, that is the ultimate goal of each one of you. That should be the ultimate goal of each one of you, is just get really good at taking care of IR patients before, after, during. So let's talk about each one of these, and I'll give you sort of my tips on how to do well in each one of these. So radiological interpretation. One of my mentors in residency told me an average diagnostic radiologist cannot be an excellent IR. And now that I'm in practice, relatively new in practice, only about 8 months out of fellowship, but I completely agree. There's so much radiology that goes into what we do on a day-to-day basis, both intra-procedurally, but also pre-procedural planning. And I'll use my prostate artery experience, since that's what I'm doing a ton of nowadays. Having a good CTA and being able to look at the pelvic arterial anatomy and map out every single vessel before we even start the procedure is immensely helpful. And that has saved that saved me hours in the procedure room, because I know exactly where to go, which obliquity to get, which artery I need to be concerned about. Is there inferior rectal? Is there vesicular? Do I have to be worried about the pudendal? Things like that. You can make your life easy with good evaluation of the CT anatomy. But to be able to do that, you got to get good at radiology. So your R1 to R3 year, that's your time to really get all that down. That's not to say you should neglect all the other things that I just mentioned, the clinical medicine and clinical IR, but that is your time to really focus on your radiology years. Do not shirk any rotation. You never know what imaging modality might come in handy. And I'll give you my example. And I'm ashamed of this, but I'll admit it, that I did not give MSK radiology a lot of my mental energy. I did not enjoy it. And I didn't do very well on it. And I just kind of, took vacations on it. And guess what I'm now expected to look at almost on a biweekly basis, an MR knee before geniculate artery embos. So it's one of those things where you just have to, you never know what you're going to encounter. So you have to be ready to be able to pick up things. And if you haven't prepared for that in residency, if you haven't spent the time looking at MR knees, you're going to be struggling. And same thing with MR prostates. I just did not give the due time to learn my MR prostate anatomy. And now I'm seeing prostates all the time. So you never know what you're going to see. So get good at radiology, spend those 3 years and take each rotation seriously. I just listed a couple resources here that I found helpful. There's a ton out there, and I'm sure a lot of these are outdated by now, but I found those 4 helpful. Of course, you all know Anki, but Core Radiology was solid. Rad Primer is a good little question bank resource. And then finally, Core Review Series was an excellent book series that I found good for board studying. Technical skills in IR, I'm not going to spend too much time here, because ultimately it just comes down to reps. You just need to do a ton of procedures, and you got to put the reps in. You will get better. It will come with time. Do not be hard on yourself when you don't get access into a basilic vein during a PIC. I remember beating myself up a ton for not being able to do that as a second-year resident. It's a hard skill, and PIC lines especially, you will be humbled by them on a daily basis. So just focus on going in, scrubbing in, struggling, and eventually you'll get better. I will say that you will learn a lot of procedural skills on non-IR rotations. I got really good at ultrasound, ironically on breast radiology, because you're ultrasounding all the time and you're trying to find lesions that are millimeters. So you get really, really good at ultrasound skills and ultrasound guidance skills on breast. In body and chest radiology, that's when you get good at CT. And then finally, fluoro, that's where you run your II and get to know your C-arm. We've talked a lot about fundamentals of clinical medicine. I think Dr. V and Zaim have talked about this at length, but I'll quickly go through it. The RFS critical care curriculum is a fantastic way if you want to go and brush up on your clinical medicine. We created that about 5-6 years ago. I think it's still on the website. It's a solid way to just kind of brush up on pressors and how to manage a patient in respiratory distress, and it's curated for the IR. So that's, you don't have to go, deep diving into it, but it's something you do need to learn. M4 rotation, we've talked about the importance of having a robust M4 year. Surgical intern year, Zaim has done a really good job talking about that as well. And then clinical IR. So I've listed a couple of books here. I think you've already heard about IR Playbook and JVIR. I'll just plug in a book that I worked on a few years ago and published with SIR. It's a pocketbook of clinical IR. It's meant to be read in a week. It's kind of like the Pastana of surgery. That's how we modeled. That's what we modeled it after. It's one of those books you pick up, you can read cover to cover in a week or two and put it aside and then focus on some of the more robust textbooks like IR Playbook. The main thing, though, the takeaway there is that you just need to read. IR is changing so rapidly that you just have to consume as much literature that's out there. And as I mentioned earlier, not just in IR, not just in JVIR, IR-centric journals. Go out there and read what urologists are saying. Go out there and read what the orthopods are saying, or what the hepatologists are saying about PVR tips or whatever. Just to read. And then finally, the importance of IR clinic. To get really good at clinical IR, it's not enough to just take care of the patient's inpatient. You got to go to the clinic, and if your program doesn't have one, that's you need to work. You need to talk to your PD and see how you can get one, because it's a must. And I have fellows and residents that come to my clinic here and there, and they're always so focused on procedures, and I'm trying to tell them this is far more important. You're already going to be fine at procedures when you graduate. What you won't be is how to run an IR clinic. So I'm very fortunate in that I have a very robust IR clinic, and I see all my patients pre-procedure and then follow them up longitudinally as often as I need. So one last thing is, a lot of medical students say to me, or residents say to me, that, hey, I'm at a residency program that isn't clinical. My challenge to them is change the culture. It's on you. Most surgical subspecialties that are out there, the residents and fellows are the face of the specialty. It's not the attendings. It's actually the residents and fellows that you interact with far more. So go and be that change. Go, if you don't have an inpatient rounding list, make one, and start adding patients and forcing your attendings to run the list every morning. And finally, read up. I can't emphasize that enough. Just read. Know your disease processes inside out, so that when you graduate, you're ready to fly. Communication, rounding, leaving daily progress notes, communicating with your team. Those are all things that surgeons are very good at, and IRs have to be excellent at. So do all those things. That's what's expected of you. Ultimately, what is the goal of IR residency? When you graduate, what do you want to be? Who do you want to be? And you should be striving to be a clinical IR and to build a clinical IR practice. Dr. V and I have chatted about this for hundreds of hours over the last 9-10 years. And, I didn't know when I graduated whether or not everything that we talked about was going to be successful, or everything that we discussed would amount to anything. Because I don't know how many times we've talked about this, but it wasn't until I graduated fellowship and I was no longer under the watchful eyes of my attendings, and I could kind of do what I wanted and practice the way that I felt IR should be practiced, that I started seeing how helpful and how important all the things that you've heard in the last hour and a half were for my growth. And I'll share with you a couple of cases that I've done as a direct result of some of the things that I've mentioned to you in the last 10 minutes. My big focus in the first 7 months of my career have been building up a palliative care practice, and these patients are difficult. The palliative care, I gave a talk to the palliative care team, and that's where the referrals started coming in. And these patients are challenging because you don't really know. They'll tell you something vague. They'll tell you patient has cervical cancer and has pelvic pain. Pelvic pain can mean a lot of things. you have to go talk to the patient. You have to go figure out where the pain is. And this is a patient who had prostate cancer, had pelvic pain. And when you dug deeper, you find out that he has intractable penile pain. Pudendal nerve cryoablation is something we can do for that. So this is a patient that I did a pudendal nerve cryoablation on. And here are the probes. This is a pudendal canal here, the Alcock's canal. And we did a nice successful pudendal nerve cryoablation. Patient's pain went from 8 out of 10 to 1 out of 10, went home the next day, not on any opioids, and lived the rest of his life pain-free. Second, and of course, this is all, once I did that procedure, I saw him in clinic, I talked to the team, all the things I told you about, you got to do that. Another example of pelvic pain. This is a patient, I believe, who had rectal cancer, who had pelvic sidewall pain, and the targetable usual culprit is the superior hypogastric plexus. And again, got him teed up, saw him as an inpatient, figured out exactly where his pain was, and did a superior hypogastric plexus block and ablation, and patient did great. And there's what you should expect to see when you do an injection under an AP view. This was a patient that I saw that I was actually consulted for a filter placement. And when you dug deeper as a consultation, when I saw the patient for a filter, I started digging into his chart, and I realized this guy has a hormonally active adrenal mass that was not, he was not a surgical candidate because his cortisol levels were so high that his wound healing was awful. He had essentially no wound healing whatsoever because of his high cortisol levels. So, I chatted with the team, chatted with the endocrinologist, confirmed that he was not a surgical candidate, talked to the family, and offered him a cryoablation. And this is just my intraprocedural CT that I got. It was a 8-probe cryoablation, went really well. As you can see, it was nestled beautifully between a lot of important structures, but patient did great. We got great margins, and his cortisol went from 42 to 16. This was back in August, my first month as an attending, and he did wonderful. His cortisol levels normalized, and his wounds healed, and he's still alive and doing great. So. And then finally, as I mentioned, my prostate artery. This has been my work in progress for the past 6 months. But again, if you apply all the things that I talk about, you can do these as a first-year attending. You can hit the ground running and take care of these patients fully from start to finish. And there's one of my first ones that I did. I was really happy with how things looked from on my cone beam CT. So again, I think my goal with this talk was to give you a blueprint of how to succeed in IR residency. And then the last few cases that I showed you, my hope is to show you that this is what can result if you practice IR the right way. I'm to this day, I'm amazed that that I'm allowed to do this. I mean, it's a privilege. It really is. And to me, this is the best specialty in medicine. I could not have thought about. I can't imagine myself doing anything else. I love what I do, but my only request to y'all is practice it the right way. Text me anytime. Seriously, I love talking IR. Text me anytime, and if you need help, mentorship, if you just want to talk about how to do well, or if you're interested in Michigan IR, please let me know, and we can chat more. Thank you.